Good afternoon, ma'am.
Hi, Saji. How are you?
I'm good. How are you?
I'm good.
You came to the Pedicon, right? I didn't got a chance to meet you.
Yeah, meaning I couldn't like all were strangers for me. I did meet a lot of people who I know,
Okay.
but I couldn't meet you. Neither could meet Dr. Neelam. That's what we were discussing. We didn't have a chance to meet each other. It's
I was
really a lot
busy.
of people, anyways.
I was busy like anything. Crazy. I was running around like
I
anything.
can imagine. I can imagine the way the situation was also.
Yeah. So net was like we had to finish things. Things are back and forth happening. Baap re baap. It was like crazy.
Meaning, I did try to chance upon people who I already know, but somehow I couldn't really. And I had brought my mom also along with me, and she was keen on going on temple visits and all that. So I had to arrange for all
Oh.
those things also. It was a nice trip.
Yeah. One second. हाँ सर. हाँ चालू है सर. क्या दिखा रहे हैं? एक मिनट सर, एक मिनट में देखता हूँ.
I'll keep it ready. Are we expecting anybody from IAP?
Yes, Neela madam, Ruchira madam, all are coming. I've told them, I'll
Okay,
just call them again. Yeah.
okay.
Good evening.
Hi, good evening. Good evening, Dr. Mohammed.
Very good evening.
Good
Hi.
evening.
Hi.
Good evening, Dr. Vanitha.
Good evening, Dr. Ruchira. We are meeting for the first time. I'll have to
Absolutely.
introduce myself. I'm Dr. Vanita, and Dr. Mohammed is the IAP Bahrain president. You can see him there. It is clocking 6:30. I guess we can get started. I hope to have Dr. Neelam as well. In the meanwhile, I will go with my introductory talk and then get started with actual CME in due course of time. So, good evening. Welcome all. Welcome back for another session of IAP AMH CME. For those who are familiar with this IAP AMH collaboration, my apologies for being repetitive. IAP collaborated with American Mission Hospital the last almost 1 year and plus with an idea of betterment of pediatric practice in this part of the world. But as it happens, we have reciprocated this model leaps and bounds, and our outreach has been beyond the borders of Bahrain and well received in India as well. So the as I would take pride in saying, we have completed 13 sessions, and this will be our starting session of IAP AMH 2026 CMEs. What changes here is we have this would be under the vibrant leadership of Dr. Neela Mohan, and she needs no introduction. We hope to reciprocate the same vibrancy with some innovative products in the CME. The basic model of every month having one subspecialty and collaborating with a local speaker to give the insights of local concepts in the same theme would be how we structure our CMEs. An additional Focus Plus is the introduction that we are starting in 2026. So what would this Focus Plus be? It would be a short 15-minute concept of introducing focus for beginners, showcasing focus as a tool for clinical decision making and taking people who are not very familiar with the concept of focus in the stride of getting it into focus. Focus is no longer an optional tool. It has become an extension of clinical examination. So we thought consistent, repetitive, 15-minute showcasing focus as a concept to the practicing pediatricians would be of value, apart from our original theme of one pediatric subspecialty every month. So here we are at the inaugural session of IAPMH CME of 2026. I can see Dr. Ruchira. I would welcome Dr. Ruchira to give you introductory words while I wait for Dr. Neelam before getting started with the actual CME. Dr. Ruchira, please.
Look, Monday is
Thank
welcome.
you. Thank you very much. Saji, please call Madam.
Yes, ma'am. I have informed her she was supposed to join.
Okay. Okay.
Look, Monday is already joined.
Yeah, I've seen Dr. Bhandari, sir.
Okay,
So,
Dr. Ruchira, your words, Dr. Mandari. While we wait for Dr. Neelam, we can go ahead with our introductory talks, please.
thank you. Thank you, Dr. Vanita. It's truly a pleasure meeting you on this platform with you and lot many other dignitaries. So a very good evening, respected dignitaries, dear colleagues and friends. It gives me immense pleasure to welcome you all to this AMH-IAP webinar, a wonderful academic collaboration between IAP, Central IAP, and American Mission Hospital together with IAP Bahrain branch. So today's theme, Dr. Vanitha, I really want to congratulate you because focus, that is the theme is focus for practicing pediatricians. It is extremely relevant in contemporary pediatric practice. point of care ultrasound is no longer just an adjunct. It is becoming an extension of our clinical examination, helping us make faster, safer, and more informed decisions at the bedside. So, what very fondly people say, that's a newer stethoscope in our pediatric practice, more so in PQ. So I sincerely appreciate the efforts of organizing team across the borders who have made this academic exchange possible. Such collaborations, they truly reflect the spirit of IAP, sharing knowledge, building capacity, and strengthening global pediatric partnerships for better child health outcomes. So we are truly privileged to have an outstanding people with us. I'm confident that this introduction on focus session and its application in real life clinical dilemmas will be highly practical and enriching for all of us and all the pediatricians who are watching this particular episode. I also want to acknowledge the enthusiasm of our members who actually continue to prioritize learning despite busy clinical schedules. Your commitment to continuous professional development is what keeps us and our fraternity progressive and patient centered. As we begin, as we begin this particular webinar, I will encourage everyone to actively engage, ask questions, and take back home the key learnings that can be translated into everyday practice. I'm really thankful to our president, Central IAP President, Dr. Neelam Mohan Madam, who's again a very visionary leader. And under her leadership, we are witnessing ample of such kind of programs which are definitely taking forward the legacy of yesteryear's leaders, and also her vision is taking IEP to a newer height, and we are sure that we will achieve extra miles during her leadership tenure. On the behalf of IAP, I extend my best wishes for a very successful academic session. And I thank you, the faculty, the participants, for making this initiative a thoughtful one. And I am looking forward to more and more interaction with all our colleagues in Bahrain. Thank you very much, and I wish you all a very, very engaging webinar and a very, very, what should I say, successful collaboration across the borders. Thank you very much. Over to you, Dr. Vanitha.
Thank you, Dr. Ruchira, for those encouraging words. I would want to see if Dr. Neelam is here.
Yes, madam is in.
Dr.
I'm there,
Neelam Mohan.
Vanita. I've been listening and admiring all of you all and the enthusiasm.
Hello, Dr. Neelam. Dr. Neelam, the IAP president, needs no introduction. Dr. Ruchira already gave a brief introduction. Today, we are having the first session of IAP AMH CME 2026. So I made a brief introduction. I would want your encouraging, as always. It's been very, very nice to have you around with these encouraging words, and we would get started with after such
Just two,
introductory
three
words.
words. I think I don't want to come in that time. Ruchira gave a very extensive deliberation today. So she took off the role of the president. So the president doesn't need to speak. That's the team. Anyone speaks, it's for all you all. I just want to say thanks to beloved Pejavar, and thank you. I requested him to continue for this time too. And besides Vanita, my huge applause and a praise to Mohammad Salman. And what a topic! I'm absolutely looking forward. More power to you all and more learnings. And thank you to everybody for continuing this beautiful platform of IP Bahrain digital platform.
Thank you, Dr. Neelam. Dr. Mohammed
Thank,
Salman, a few
yeah.
from you before I go ahead.
Thank you, and good evening for all. I think our program now is a little bit more recognized by the some professional from outside Bahrain and India. I receive inquiries from doctors from different parts of the world to be part of this program. And this year, I think we have 2 or 3 speakers will be from the different part of the region. They just willing to share their experience in pediatric, and I think this is a good and a very nice progress to the IAB AMH progress. And from the beginning, we saw that so many attendees are joining the seminars from different parts of the world. And I hope this will be a good progress and to move forward to be an global initiative collaboration. And I will leave the floor for Dr. Vanitha to start her presentation. I think Dr. Vanitha is well known, and most of the attendees know her very well. And she is the professional and expert in the podcast, and she wants always to share her experience and to teaching us how to using the podcast in our daily practice. Dr. Vanitha.
Thank you. Thank you, Dr. Mohammed, for that introduction. For those who are not familiar with our structure, Dr. Mohammed is the champion of scouting resources of speakers from this part of the world, and we've had more participation. Exclusive thanks for Dr. Mohammed for this. Thank you very much. Now I'll get started with the content of today's CME. First part would be to introduce Focus Plus. As I introduced in the initial talk, Focus Plus would be a model 15-minute recurrent CME every month as a adjunct to the existing theme of any pediatric subspecialty we are seeing. We realized that there are many workshops ongoing. There are many people who are seeking learning focus, but they stop short of continuing this concept in their daily practice. And as Dr. Ruchira said, it's a daily accepted concept in PICU. But my focus today is to introduce it to practicing pediatricians and to make them see the value in this invaluable tool. We will go ahead and see. So this is the reason I included this as a recurrent CME every month along with the existing model of subspecialty CME. So this is called Focus Plus. So what is Focus Plus is to translate the image learning. People get overwhelmed with learning images. We will demystify this concept and take it to the hands of practicing pediatricians where it has more value. So from image to impact in practice is how I have coined the theme of today's Focus Plus. We will use this as a tool for clinical decisions, and this is where the focus will be more than focusing on image acquisition. So why workshops are not enough? There are umpteen number of workshops. Every conference we see, there are workshops that are encouraging people to participate, learn, and focus is 5 years before, focus was just a concept. Focus now is everyday learning in the PICUs and ERs. Now let us see why Focus Plus can add value to every pediatrician who are thinking that focus is not for them. Focus is an overwhelming concept. Though we have learned scanning, we all struggle with when to use it, when to scan, what to scan, how much is enough, how to integrate these findings in our decision making, what to document, how to document, and what's the concept of focus documentation. So many of us have learned focus, but we still hesitate at decision points. So we are bringing in this concept of Focus Plus, wherein our learning will be translation to practice. There are decision points of, do we give fluids? Do we stop giving fluids? We stop bolusing, we add, is this time to escalate care? Is it time to do CT? Is it time to admit? Is it a concept of needing antibiotics or bronchodilators? We will go more in depth about what I'm talking about. These are the gray zone every pediatrician faces. And if we have a tool which converts this gray to black and white, we would be much helped. These are not rare cases, these are everyday encounters. And what we want to see is how to utilize focus in this. This is the gap we will try to fill in our sessions of Focus Plus. So what's Focus Plus? It will be clinical trigger-based scanning. We will encounter a dilemma. We'll base our scanning based on these dilemma. We'll use a couple of windows, focused decision windows. We recognize the patterns. Then we convert it into a decision node. Then after deciding, intervening, we will reassess, we'll review, and this will become a culture. This would be the Focus Plus culture. So why this matters to us, the practicing pediatricians? It helps us to improve our diagnostic confidence. The gray zone is converted into confident decision making, reduces unnecessary referrals, it detects early deterioration, it avoids harmful assumptions, it builds image interpretation skills, creates peer review culture. Most importantly, it converts this ultrasound focused learning from just an interesting tool to a decision making instrument. So always, whenever you attend focus workshops or learning focus, it is used as a tool to make a binary decision. Do we give fluids? Do we not give fluids? Is it a full bladder? It's an empty bladder. It wouldn't be just that. As we evolve into Focus Plus, we will further upgrade, use it as an integration in a whole body assessment, not overwhelming, a simple few focus steps, understanding that it is an interaction of different systems that we need in decision making. So it gradually progresses to from focus questions to pattern recognition to integration to in an undifferentiated situation or an unstable child where just one organ focus may not be sufficient. So we will begin with binary interrogation and we'll progress to integrating it into decision making. For example, respiratory distress may possibly be a focus in the lung, but it may not be sufficient to end in lung. As we see, we assess the heart as well. So we go step by step, go lung, heart, IVC. This would be integrated focus. So this is how we plan to do. We understand these children don't fail by individual organs. The physiology is more complex, and this complex insight we can gather from focus by integrated multi-system focus. And this would be also how we go about learning Focus Plus. So this would be focus with as well as integrated focus. We start with a single dilemma. We use 2 or 3 interrogating windows of ultrasound. We probably get an immediate answer. We intervene, or we will integrate it in. If we more often than not are faced with situations we are in an unclear situation, unstable situation, undifferentiated situation where we integrate multi-level of focus and make decision making with complex situations. This is how we have positioned Focus Plus, and we will see how we go about this. So Focus Plus will be a monthly ultrasound case forum. We'll have a theme-based learning. We'll use real pediatric cases. We'll review images. We will see how decisions are made, decision analysis based on focus imaging. And we'll focus on what we scan, why we scan, what changed by using the focus. And we will evolve from learning how to scan to applying it to dilemmas. It is said learning is the easiest part. The scanning, image acquisition can be done very easily. Although many new learners are overwhelmed and reluctant to enter the arena of focus. Some skepticism as to why we should learn. We have been practicing for ages, we have guidelines. This is integrating these guidelines and visualizing it by using focus and applying these physiologic principles with an integrated fashion is how we will evolve. I can tell as I learned focus, my evolution has gone through these stages. My dilemmas are more clarified. My application of these focus learning and decision making has made my decision making more sharper. So this is where I would want to walk along with fellow pediatricians by applying focus skills. So integrating it into whole body thinking, then we will build slowly structured review culture. So this is what the focus plus plan would be. Every month will be a different theme, and it would be limited to a 15-minute, multiple cases, real cases, and reviewing the cases image-wise. So this is a rough calendar I have planned for month 1 to 6. We will try to abide by this so that the participants can exchange some of their images and bring forth more interactive discussions. So Focus Plus is not about scanning more, it is about utilizing it for decision making, and it's about deciding better. So that's what Focus Plus is for you. I'm hoping this is the introduction I wanted to make. This is the first part of the talk, introduction to Focus Plus. So I conclude here, and I'll get started with the actual CME to pick your interest more and focus. This will be clinical dilemmas, everyday clinical dilemmas that we face. You can identify with many of them and how focus helps. So let me stop here and go to the actual CME. Welcome back to the second session. The second session is titled Focus, where focus matters most, clinical dilemma encounters. So what follows would be image review of common encounters. You can make it interactive also. That would be also welcome. So let me get started. Case 1, the third bolus. We all are familiar with the surviving sepsis guidelines. Encountering a septic shock, we are encouraged to initially handle. I can tell you, we predate. I am introducing focus after 2 boluses of 20 ml per kg. This is where I'm introducing focus. This would be the dilemma. Do we continue? We have given 2 boluses, 40 ml per kg. Dilemma would be there is still hypotension. Do we continue giving another bolus, or the clinical information, apart from the fact that hypotension persists, is not helping us make a decision? So how do we go about it? We are faced with a dilemma. There is still hypotension. Do we give another bolus, or we do a focus? So when we do a focus, we can do 2 focus windows. One is IVC. The first window, it is not very difficult to appreciate. This line is what IVC is. Even for people who are uninitiated about, you just have to put the probe in the requisite place. And if you see IVC of this nature, or an IVC that is inferior vena cava of this nature, can help you make a decision. There are lots of caveats here, but as I said, this would be to just sought the theme of clinical dilemmas. So you are in a juncture where you want to give fluids or not. There's still hypertension after 2 boluses. This is the IVC you see. Then you are already in a situation where this is called a plethoric IVC, which is not varying with respiration. You're already faced with a situation where fluids have loaded system adequately enough, but have not helped the situation of hypotension. So we no longer have a fluid responsive hypotension, or we can call it fluid refractory hypotension. And you exercise interrogating another window, which is the cardiac feature. There are 2 windows. This is called flax view. You see a heart which is barely contracting. There is no squeeze. The valves are not beating against, squeezing against the wall. So mitral valve is barely trying to reach the septum. Whereas this will be a window where it's hyperdynamic, it's beating faster, harder, and hyperdynamics, that is squeezing faster than expected, and the walls are almost touching each other in the diastole also. So you just have to interrogate these 2 windows, and you have sorted the dilemma in the next 3 to 5 minutes. So if you find the IVC which is plethoric and it's already function, they will have an answer. Fluids can only damage further, so you stop fluids and you start an inotrope. Let me go to the second case. You have a case of diabetic ketoacidosis. You have achieved metabolic correction. When we are dealing with DKA, we are all aware of how stringent, how many revisions the protocol has gone through, and all with a primary focus of avoiding cerebral edema. This is the one-time dreaded complication, and it is ridden with mortality. So people are focused in preventing early recognition, managing cerebral edema. This would be the focus in handling DKA. And we all know it does. Most of the cases of gross cerebral edemas happen with severe DKA, and so the manifestations are before handling the situation of management. But when it evolves, how quick you can capture it would be how the decision-making dilemma would be. So you're having a case of DKA. So the day 2 of management is metabolic correction. Whilst you notice the child complaining, it's a 10-year-old child complaining, headache. So you are having a dilemma. This is after resolution. You're having a child with headache. Are we handling a situation of cerebral edema? Do we panic, rush to escalate, do the CT scan, or we observe, or we manage? So at this dilemma, there is a POCUS tool which can help facilitate sorting the dilemma. This is called ONST, a tool where you interrogate the eye, you know the dura extends over the optic nerve, reflecting the changes of raised ICT over the optic nerve. This would be reflected as widening of the optic nerve sheath. That is the sheath enveloping the optic nerve. So it's a very easy capture. When you do it, and then behind the keyboard, measure the width of the optic sheath, and there are landmark measurements which will guide us to think there is raised ICT or not. A standard elevation beyond 5, or more often than not, serial measurements will guide us whether this would require intervention or not. So your decision of increased diameter plus on serial monitoring, further increase. Serial would be at junctures of every 15 minutes. If you see increasing ONSD, it's already an indication for you to escalate care. You give early hypertonic saline, avoid worsening of cerebral edema, or you don't need any other interventions. You probably can monitor resolution hand in hand. So you make the decisions of escalation to ICU, you give hypertonic saline bolus, and you're already sorting the issue in this dilemma. So this was the 0.8 m 0.89, that is 8.9 mm, is already very high ONSD, reflecting above 7. It is said it probably doesn't go in a sequential way, reflecting the ICD, although upfront this is raised ICD, and rightly so. It was intervened with hypertonic saline. This is how it is done: 3 mm behind the globe. The width is measured end to end, which in this first situation, it's normal. This is the patient. Okay, this becomes more interesting. We all are encountering respiratory cases. They can be a daily intervention, daily encounter, or emergency. So, child with cough and fever, very common encounter. This is the ultrasound. I described it. It was a 6-year-old child, had cough, fever, some focal lung findings, mild respiratory distress. X-ray was done. It was negative. 6 to 8 hours later, child presented to the ER again. Then this was the ultrasound. Here is very pathognomonic of pneumonia or consolidation. What happens is you see the pleural receding margin of pleura, which is called the shred sign, and the air trapped in the bronchioles will be seen as something called as air bronchograms, which is known as respiration, which is called as dynamic air bronchograms. All that is needed is to elicit these signs, and as pathology sets in, the lung ultrasound becomes more easier to acquire the windows and findings, and very informative. So as we saw here, a chest X-ray negative with symptoms, it could be any of the respiratory things, and if a chest X-ray is negative, by and large, our assumptions become as a transient respiratory finding of probably viral bronchiolitis, pneumonia, or even bronchospasm. So ultrasound gives you more insight into clinical decision making in these situations. So a same child or a different child with an interrogation which reveals A lines. This is again a very easy acquisition. You see A lines in all the lung fields. This would represent well-aerated or even hyperinflated lung. So you're having a situation where there is respiratory distress, but when you're interrogating, you're finding good, crisp pleural line with good aerated lung. This would mean it's a hyperinflated lung or bronchospasm as the pathology. Whereas the same clinical picture, if you see a picture like this, vertical artifacts like this coming shooting out of the pleura and it's uniformly distributed, this would mean it's a wet lung. A wet lung would cause the same clinical examination finding of wheezes and respiratory distress. But when you interrogating a classic difference between A profile and the B profile will distinguish two different pathologies. So this was a child presented with RD, but when you did, what you found was this. We actually discovered a viral myocarditis whilst we were treating it as acute bronchospasm. We realized it was actually, with the next step of interrogating the heart, that it is not simple bronchospasm, but and it can worsen the situation treating it like a bronchospasm. So it was actually affected heart, which is causing pulmonary edema. So case 5, a child with cough and fever. Here, the child with cough with diffuse adventitions. This is a clinical examination finding. There was respiratory distress, there was hypoxia, not much different from the child before. But this is what you found in the lung ultrasound. You see V lines also irregular pleura. There are lots of uniform irregular pleura, which is sonologically called a subpleural consolidation. Close of what subpleural consolidation would be something like this. So if you find scattered such subpleural consolidations and with concomitant B, it's already suggestive of a viral pneumonia or acute bronchiolitis. This has been part of guidelines now. If you find a clinical picture may not be conforming, it may be a well child, just febrile child, minor fever and cough. But if you see these subpleural consolidation in the posterior field, you already know the higher oxygenation needs. You've got an insight into this. So the guidelines are prompting us to escalate care or keep observation and not send away as you would have clinically decided to pursue further on care in acute bronchiolitis of RSV. So these are the subpleural consolidations. Let's see the next case. It's a 4-year-old boy of mild RD bilateral V's. RSV is positive in the rapid antigen set. We all know 4-year, it may not bother much. But since there was a lot of V's, bronchodilator treatment for hyperreactive airway was the plan. Lung ultrasound was incidentally performed. As I said, it revealed generalized B lines and good sliding. We already saw in one of the slides before, something like this would mean more of pulmonary edema. That is a lung which is wet and it's a reflection of cardiac dysfunction. So we interrogated further all the fields. There were no subpleural consolidation like I demonstrated in the earlier slides, no A lines like asthma, but generalized B lines with good sliding. So what this means is we will have to go to the next step of doing cardiac focus. It revealed poor global contractility. Again, this was a viral myocarditis. There was a child of bronchiolitis. On the routine care required respiratory support, ventilatory care. Further, hypoxia was worsening. One would think is worsening of bronchiolitis, clinically speaking. Dilemma, is it severe RSV or is there any atelectasis as is common with bronchiolitis? Or so severe RD, suddenly we would have to keep few more differentials rather than just severe RSV, severe bronchiolitis. So again, focus came to give us insight there. So we saw the earlier slides, shred sign, dynamic aerogram, and some anechoic shadows. What this means is this is secondary pneumonia. So promptly speaking, we added the antibiotics. So this would clinically be not very suggestive of pneumonia. We know when we're handling bronchiolitis, any worsening, any RD, all we know is it's the severity of bronchiolitis. So whether it's that or is there atelectasis, atelectasis again can be determined by the same kind of picture, which is not dynamic. That's the only slim difference, and we will know as we get smarter with focus. This is another interesting case when we have a neck swelling. It's a gross red swelling. You always think of an abscess. Draining, to drain or not would be our dilemma. So just a focus will distinguish it between a reactive lymph node, or an abscess. An abscess will have a complete anechoic area with no Doppler flow in the indicated region, whereas a reactive lymph node will have a hyperechoic hilum. So when you see something like this, we know it's a lymph node reactive, so we'll avoid surgery. The next situation, there is a thorn prick, and a child brought a couple of days later with a swelling in the foot. It appears like an active abscess. One would possibly plan on draining this, but a focus and a Doppler revealed a different story. Again, just a focus revealed an abscess. The same Doppler revealed a classic Hemanian appearance. This is a pseudoaneurysm. If you needle this, you will know what we'll have, a disaster. I would request participants to mute themselves, or Saji, can you please look into this, muting everyone? Sorry. So a foot swelling, which appeared like
I can mute, ma'am.
when interrogated with Doppler, revealed a pseudoaneurysm there because of the injury. So again, focus came to our rescue. This is how various focus scenarios can help us and avert disasters. So this is another very useful application of focus. Swelling on one look, this would appear like probably an abscess or cellulitis, you could never say. So, but you can actually say, when you do, you have a choice, drain or not. With this presentation, you just put a probe. A cobblestone appearance like this is indicative of cellulitis, whereas anechoic area is indicative of an abscess. It's as simple distinction as that, and it's a very useful distinction. And there are very many protocols which urge you to do this prior to doing IND. So a decision making is so crisp when you use a tool of focus in these clinical situations which I pose. So let's go for a situation where we have a status or a seizure which is just controlled. Post-recovery, you notice excessive drowsiness. It could just be post-ictal situation, or is it not? Is it raised ICP? We saw an earlier situation. We do something called as ONSD. If an ONSD is wider, this is already beginning to be wider than the indicated size. It's 5.9, almost 6, which means it's raised ICT and already prompting you to escalate neurocare. All these are situations which we've all encountered. So toddler fell off bicycle, trivial trauma brought to it's a toddler bicycle. He is suspected to have gotten injured by the handle of the bicycle. He is very stable. He is happy, laughing, silent, good child, close to you in ER. So your dilemma, you clinically feel everything is fine, you can send home. This is a stable child. So you have a protocol called eFast. When you interrogate relevant areas, you can see if there is any free fluid indicative of any bleed. If you see that, it's an indication to proceed for surgery. So a decision of referring surgery, CT scan, it is said it is not very sensitive to pick solid organ injuries. So EFAS negative may not be a situation where you can discharge, but EFAS positive can help you make a decision that there is hemorrhage already. Clinically, it's not reflected, but you've already got a situation where there is suggestion of hemorrhage. So you wouldn't discharge, you refer, you observe, then it's a surgery. Okay, so this is the view. This is behind the bladder. You're seeing it's the most dependent area in the pediatric EFAS, and you're seeing free fluid in the area. This is EFAS positive. So what do we have common in all the presentations, all the cases that we presented so far? These are all very common encounters. these all have diagnostic uncertainty, then you are faced with a dilemma to do this and not to do this. So using focus gives you more certainty, it reduces the delay, and you're not just empirically just doing something or escalating care and avoiding the after effects of such non-focus interventions. So the next step, we all saw using one or two windows how we could sort some dilemmas when that is not enough. So this is where the next step of focus, which is again not as complex as it sounds. You know the pattern. There are a couple of situations. We are all mature clinicians. We know when we are assessing the lung, what next would be is to assess the heart, and when we are assessing shock, what next would be to assess the mentation, the fluid, urine output, the peripheral vasculature, etc. So it's the same logic you apply and use the relevant windows to get more certainty beyond one or two windows. So when focus scan is not enough, situations like undifferentiated sick child, you don't really know. It's just a sick child. You examine step by step different systems, and putting it all together is how you make a picture out of what's happening. Or it's a clear picture of shock and it's persistent and not responding, it's refractory. Or a situation where you cannot explain why deterioration is happening, or situations where there are mixed signs, you cannot make a pattern out of it, or there are different systems involved. So these are the various windows and focus applications which will be integrated to give you a more advanced focus insight, which is called as whole body or mouse. So these are a couple of them integrated together. The idea of today's presentation is to get people to be interested in this and people who are already into it to get more interested in how to apply it in clinical decision making. So as we go further, we will know how useful integrating these things and how not as complicated as it sounds before we are embarking on it. So this will be the whole body map. You will start interrogating the lungs in sequence, and then you go step by step, interrogating different views of the heart, at least two views, and then go for IVC. Then interrogate ONSD and the abdomen for free fluid, and kidney and bladder for any obstructive signs. So making it a repetitive practice and our regular encounters will make us understand that it's not very complex to do this. It's, as Dr. Rachira was saying, it's commonly conceived as a next stethoscope or a new stethoscope, and making stethoscope a little obsolete, although it's a championing cause for insight which window to use. Stethoscope is a leading window. So let me showcase one or two to get you interested in the integrated focus. Hypertensive child, this is something which we saw in the beginning. You see no focus. The whole body findings, you see depressed LV, you see B lines in the lungs, you see mild ascites and pleural effusion. So next 3 to 5 minutes, you're adding valuable information. This is septic myocardial dysfunction. There is capillary leak syndrome evolving. You change your management. You don't go liberal on fluids. You restrict fluids. You start early inotrope. This is when you're interrogated, couple of windows in unexplained shock. This is where you stand. So this is what we saw. This is an earlier LV dysfunction. And this is what we saw in IVC. So it's really this fluid overload or dysfunction of the heart. And B lines. This is important. You'll have to see it reflected in B lines. And you're already seeing effusion as well. This speaks about capillary leak syndrome as well as fluid overload and dysfunction. So you change gears in your management, decision making. There is no lingering effect of empirical managements of giving more fluids or salvaging the situation when it becomes an arrest because of fluid overload. So the same situation, you have a decay, there is persistent tachycardia. What one would assume is persistent dehydration. Or is it myocarditis? So how would you say, or maybe even sepsis? How would you say? Do a simple same steps. If you see a LV dysfunction, there is no IVC collapse, there is clear lungs, A lines. What we see, there is cardiac involvement, but there is no overload. But you already have an insight as to not to load. You have a cardiac myocarditis is possible because of the metabolic changes, and you have a situation already delineated. So, any undifferentiated deterioration. So, we have a boy who was diagnosed as pneumonia and is hospitalized for treatment. There is 5 days of treatment, no significant improvement. Instead, patient acutely developed progressive worsening of chest pain, shortness of breath, and excessive sweating. The PSU was consulted for opinion. There was an ill-appearing child sitting upright in tripod position. He was afebrile, 36 respiratory rate, heart rate 125, blood pressure 110/70, pulse oximetry 94, face mask. We made an empirical thought process that it is possibly resistance or worsening of pneumonia, but lung ultrasound was done. A lung ultrasound, it was assumption that pneumonia is complicated, but what we saw was normal A lines. Lo and behold, it's not even pneumonia. There's a large anechoic area in the left hemithorax. Anything anechoic would mean fluids. Further interrogation, cardiac focus revealed a large circumferential anechoic region around the heart. What is the situation here? It's a pericardial effusion, which was not even thought of as a complication to what you're handling. This heart was expecting swinging or dancing movement, and there was diastolic collapse of the right ventricle. So we were under IVC, which was the next window, dilated and not varying in size with respiration. So we diagnosed with simple next steps, cardiac tamponade, which we wouldn't have. We would have pursued changing antibiotic, pursuing care, pursuing higher respiratory care, etc. Just 2-3 minutes of interrogation revealed a totally unexpected diagnosis, and an emergency pericardiocentesis was all that was needed to salvage. Of course, it was complicated, but direction of seeking pericardiocentesis was the turning point, which was dictated only because of focus. So this was what it was. You can see this is the heart swinging, and this is the left ventricle, this is the right ventricle. You can see it closing. This valve is indicative of the systole function. You can see it collapsing. Then this anechoic area is the pericardial effusion. This is more clear that it is uncoordinated systole and diastole and as ineffective pumping. So this is what the tamponade is. This was another interesting case which I it's because of focus only. So reiterating, this would be our evolution. We'll learn the basic scanning, a couple of minutes spent on it, although we understand that focus as self-learning is quite interesting, and a lot of people are in the ambit of learning focus. Now, what we will do different here is applying it to dilemmas and seeing a multiple such cases and integrating it into whole body thinking, then begin structured review. Thank you. I am open for questions. I hope I serve to create the interest in people who are trying to get into the interesting arena of focus. And I promise to deliver such sessions which will increase your interest in this field. And it's, as we started, it's no longer an adjunct or an option. It's something which is arrived in our care, and it's essential in decision making in many situations. Thank you. So I'm open for question.
Thank you, Dr. Vanita. Very interesting. Any question from the audience?
Thank you, Anita, for the excellent presentation, as usual.
Thank you.
Yeah.
Thank you, Dr. Yogesh. Welcome
Yeah,
back.
yeah,
We can
yeah.
start with you.
So next week we have we have in the NNF Gujarat Neonatology Forum, we have a focus series every month. So we will be invite you for that focus series. One of the topic as a guest of honor or chief guest.
Thank you, Doctor.
Yeah.
If there are any questions.
Good evening. Good evening, Dr. Vanita ma'am. I am
Yeah.
Dr. Singaravelu.
Hello, Dr. Singaravelu. Haven't met you. Thank
I
you
was
for
in travel,
coming in for
but
the session.
I could, thank you, madam. I could listen your lecture. It was very well explained, madam. Need of the thing. Really, I appreciate, ma'am. And definitely,
Thank you very much, Dr.
being the first webinar of this year, we will try to collaborate very well with you all so that a lot of academics will be shared between India and Bahrain. Thank you, ma'am. Thank you.
Thank you, Dr. Singaravelu.
Okay, madam.
So, as a passing note, I would like to thank all the participants who have attended. As I said, this is an introductory talk. We will be having recurrent such sessions. Next session would be a CME on pediatric surgery. That would be the theme, and one 15-minute session on focus, as we have started this Focus Plus. A vote of thanks from Dr. Mohammed, and we will wind up.
There's
Thank you
one
all for
question.
attending.
If we can put this one in YouTube channel, there's one question. Yeah, I think we
This
can.
can be.
Yeah, we can put it.
Yeah, this is. I am actually doing it. I will share it. This is my private thing. I think Saji will give me the recording, and I will upload it in the YouTube. This is what I've been doing, and you can search it. This is IAP AMH CME. This is the title of YouTube channel.
Madam,
Yeah, once we put it, we can share the link for the YouTube. Okay, and
exactly.
Yeah.
No, we have that YouTube channel. Swaji will help you, madam. He will upload on the IAP YouTube also.
Okay, that could be done also. He can do some more editing.
It will be available in our Digi app also.
Yeah, it is Digi, yeah.
Digi.
So, ma'am, now what is going to happen from next session on? The sessions will be live on the Digi app. So there will be YouTube link. So all the Digi app, all the sessions will be available where we can go ahead and watch it.
Okay, that would be great because that didn't happen in our previous year session. So if that coordination part is taken over by IAP, DIAP also, it would be wonderful. Thank you.
Dr. Vanita, this Digi app is a new initiative which we inaugurated recently, and it is.
Yes, I did.
It's
Yeah.
been launched and it's a very good thing, very well accepted.
Emergency pediatrics, yes.
Yes.
I did attend, but though I didn't gather the whole details, I know the theme of it. Thank you.
Yeah.
That would be available for IAP members and
Yes, all
BVM.
across the globe. Yes.
Thank you. Welcome, Dr. Alok. I couldn't
No,
speak
I'll
to you
just
earlier.
request you also to just help in increasing membership of IAP. Just spread this message to Indian diaspora over there that they should all join IAP because
They're already members, doctor.
we
They
have
all
lots of
are
learning
member,
opportunities.
Community they're all part of IAP.
If somebody is not,
The
just give
outreach
them this
of this
benefit.
collaboration.
Yes.
Yes, doctor. Sorry.
Thank you, ma'am. Thank you for initiative. We will collaborate very well in future. Continuously.
Yeah.
Thank you. That's very encouraging, doctors. Thank you very much.
And I am also working to establish the Bahrain Pediatric Association. It's supposed to be by March and active officially, the Bahrain Pediatric Association. And we'll try also to conclude this association in our program in the future.
Sure, sir. Sure.
Yeah, so it'll be more
And
collaboration, more bodies to be involved in this initiative.
And I
Thank
take
you,
this
Dr. Mohammed
opportunity
Salman.
also to invite you on behalf of Dr. Singaravellu to our national Pedicon in Coimbatore in January 27. It's the biggest gathering of pediatricians in the globe. I think we are expecting 10,000 pediatricians over there. So all of you are welcome to please join there.
Welcome, sir.
Thank you.
We will send a proper invitation soon. It is. Thank you, Bandari sir,
Thank you.
for
Thank
reminding
you.
me.
Good night.
Thank you. Thank you. It's our pleasure.
Thank you. Good night.
Okay. Good night, Ji. Good night.
Okay. Good night.
Mm.